Köszönöm szépen.
Indeed, and I will like to discuss the PAM50 test and our own trials with this test. We've heard this morning that breast cancers are the third largest incidence over the world. But if we just take a look at women alone, in the case of breast cancer, yes, now I have my pointer that in this case, in both tumor-related deaths and both in incidence in women, breast cancer is the #1 malignancy. There are several ways to categorize breast cancers over the years or even century. The first categorization was started at the beginning of the 20th century up till the 1970s on using a microscope. And as with technological advancement, immunohistochemistry advancements were made, followed by molecular genetics, the appearance of molecular genetics, and we are in the revolution of these. However, in clinical practice, molecular genetics are not always completely present. One of the most novel method is one by the team of Peru, is to make a classification by the presence of a certain set of genes. You can categorize breast types, and this totally overlaps with tumor progression and the disease progression indeed. And they categorized them as follows. They made 4 groups, and this fits around 80% of all breast tumor types. There are some additional types, but those are assessed individually. For example, the endocrine and inflammatory breast cancer types. But anyway, back to this classification, you can see the luminal A and luminal B type. These are estrogen or progesterone positives, and there are HER2 positive and basal-like breast cancers, and types and subtypes. These are characterized by estrogen and progesterone negativity. And with luminal B and HER2, you can see the presence of the HER2 receptor. This is also expressed. Now let's take a closer look at these types individually. In the case of luminal A, you can see, like I mentioned, that it can be estrogen and progesterone positive, or each can be positive or negative. There's never HER2. So the level of proliferation is usually low. This means that the disease progresses much lower. The tumor does not grow as a quickly proliferating tumor type. The grade, when it is recognized, is usually lower, and these tumors usually respond well to treatment. The risk of recurrence is generally low, and depending on research results, it is around 40 to 60% of all cases. 40, 50 to 60% of all cases are constituted by luminal A. Luminal B differs from luminal A, that HER2 may be positive, not just negative. In most cases, this is still negative, but a low level of positivity is sometimes noticed. In contrast with the previous type, luminal A, the level of cell proliferation is high, which leads to a quicker development of a large tumor. Therefore, usually when first observed, the grade is usually already higher, more advanced. The response to treatment is poorer. The risk of recurrence is also higher. And this constitutes around 1/3 of all breast cancer types. Now let us continue with the HER2 plus or HER2 enriched tumors. In this case, estrogen and progesterone are not expressed. Only the human epidermal growth factor receptor 2 is expressed. Just like in the previous type, the level of cell proliferation is high, and when it is noticed, the grade is usually higher. These tumors also respond poorly to treatment. The risk of recurrence is high, and there are around 10 to 15 to 20% of all breast cancer cases. This is the incidence of this type. And finally, the basal-like, also known as triple-negative type of breast cancer. There are no receptors expressed, either estrogen, progesterone, or HER2. The recurrence is very high in this case. It responds very poorly to treatment, and in most cases it is noticed with already an advanced high grade. And this is the most frequently occurring type in young patients, and there's a strong connection with BRCA mutations. How can we differentiate and diagnose these tumor types? Since it often occurs that you need specialized tools, we can only provide a vague classification for these types during everyday clinical work. Currently, we use immunohistochemistry, which means that we use a sample from thin needle biopsy or from a surgical biopsy. We make a special kind of staining, which then we can analyze under the microscope. You can see microscopic images on the second half of the slide. You can see these images from the publication indicated on the slide. You can see the positivity for estrogen, progesterone, and HER2 receptor. The Ki-67 is the proliferation rate. The darker the image, the more proliferation happens. And in the columns, you can see the luminal A, luminal B, HER negative, luminal B, HER positive, the HER positive, and the triple negative tumors. And their images are depicted, their cytological images. But how do we address these types? If we have the opportunity to conduct more detailed research, then we can conduct a molecular gene profiling methods, which similarly to the previous presentation uses specialized microRNAs in the analysis. What happens here is once we have the sample, this is usually a tissue sample, we extract RNA, and then with a method called hybridization, we locate the gene copies of genes that are present in the tumor, which is produced by the tumor. This is all introduced into a machine where we determine the microRNA amount produced by the tumor, and finally an analysis is conducted that shows us the number of RNAs, types of RNA extracted from the sample, and this generates us a pattern which is characteristic of each type. Here you can see an image from a manufacturer's website. Red means overexpression, green indicates underexpression, and the colors in between indicate transitional places. And you can see how you can categorize based on this pattern, luminal A, luminal B, and all the B and all the other ones show a different pattern. We can analyze these patterns, which aids us to compare the expression levels of certain genes and ultimately to determine the type of tumor. But what is this PAM50 testing? It is basically a test involves a package involving 50 genes. You can see them listed, their abbreviation. These are characteristic genes for this tumor, and depending on which one is over or under expressed, on what the level of the expression is compared to each other, we can categorize the tumors. So basically, this is a diagnostic tool. In addition to that, the manufacturer also includes risk of recurrence score, this ROR score, and there's also a 10-year recurrence risk score in the package. This is interesting in terms of identifying the patients who we have to pay more attention to because they have a certain risk that their tumor will start to recur sooner compared to other patients. So they are at a greater risk of recurrence, even if the tumor is resected or removed from their body, as mentioned in the previous presentation. Despite the fact that the PAM assay provides valuable information about the breast cancers, they are rarely used in a clinical setting for a number of reasons, partly because they are very costly. These techniques are still more expensive and more labor and tool machine intensive, and there is very limited amount of data available from the real clinical practice as to the performance of these tests. So our research group, tested our own set of patients to see after the PAM50 test how similar results are gained compared to routine pathological assays, to the results of routine pathological assays. And we also wanted to see whether the manufacturer provided ROR scores are indeed useful in a clinical setting. So this was a retrospective clinical study. So these patients were in advanced stage in their treatment, but their tumor samples were readily available. We conducted this. We involved patients treated between 2017 and 2021. It was very important that all the patients had enough samples to conduct the extra immunohistochemical as well as genetic studies. So they all needed to have enough samples stored. Well, yes. We involved 42 patients in the study. Here you can see the routine clinical pathological characteristics. Around the average age was around 60 years, roughly. They had mostly invasive breast carcinomas. All of them, the tumor size differed. 12 of them received neoadjuvant therapy, and all of them received one or another sort of therapy, radiotherapy, targeted therapy, chemotherapy, and around 55 months was their progression-free survival rate in months. The PAM50 results showed that 18 patients were classified as luminal A, 10 luminal B, 8 patients were HER2 positive, and 6 patients were classified as carrying basal-like tumors. Their ROR scores you can see in the table below, what the manufacturer provided. They also provide categories for these numbers. One patient was missing for one day and another. 8 patients were categorized in the low risk, 13 in the moderate risk, and 20 patients were categorized into the high risk category. We also took a look into what we see with the survival versus the cancer type. In luminal A and B, there were no significant differences revealed, but the risk is much larger in the luminal A type as opposed to the luminal B. But compared to luminal A, HER2, and the basal type, there is a much greater risk for progression. You can see a 20 to 32-fold risk in any sort of disease progression, whether that be a recurrence or a metastasis. This is what we noticed in the other types as well, that there are no significant differences, although the case number was quite low, the population was quite small. Just what we see, the actual results mirror the theoretical results. The more closely we get to basal type, the more increased the risk of progression becomes. And just like I have mentioned before, in the target of our study, we also took a look at how well you can compare immunohistochemical results, how well they shape up or compare to the PAM50 test. And what we saw was that overall, there was not such a big correlation between these two results. The green areas indicate a higher level of co-results where the similarities were later. In luminal A, we see that the traditional and molecular analysis provided the same results. With luminal B, the results were more mixed. The genetic tests provided a 40% overlap with the traditional results. And with the triple negative ones, we got a low level of correlation. We identified this with a Cohen's-Kappa correlation, and there was a mid-level correlation between the two types of immunohistochemistry and genetic measurements. So we observed that routine clinical characteristics and gold standard molecular subtyping are not completely overlapping, only largely aligned, and similar results were found in the literature in the work of 3 different research groups who published their results in recent years. So based on this, what we hypothesized that PAM50 is best to test breast cancer when ER and/or PR is below 35%. And in samples where the tumor response to a given therapy fails, so you have to change therapies after a while, then probably the tumor type is not well characterized with the traditional methods. Or in the case of grade 1 tumors that are in categories larger than PT2, in grade 3 tumors that are under PT1C, and we also identified a population of patients who still require hormone therapy after 5 years. It is important to mention of the PAM50 test that it is endorsed by a number of international organizations, for example, ESMO, ASCO, also indicates them in these guidelines, that mentioning that these genetic tests may come useful in typing breast cancers. And just a little take-home message. There was a recent publication by a Swedish group. Swedish guideline also mentioned the PAM50 test as a recommendation. They examined this in a real-world setting, how great the correlation in therapies, how well it correlates with the PAM50 test. And in 41% of the patients that had a change in the decision for adjuvant treatment based on the PAM50 result, or their original therapy was not started due to the result of the PAM50. And of these 148 patients, there were 52% of patients where we could completely avoid chemotherapy without a recurrence of the tumor. And in 23% of these who received no therapy, although they would have required therapy, so where the PAM test, so to speak, provided an incorrect result. So this is not a golden bullet, not a single test. There's no way that a single test can provide reliable results. Additional tests are required. What we can conclude from the existing literature that there, based on a number of clinical aspects, these genetic tests, together with the traditional typology and testing, one can achieve a more accurate prognosis of the cancer patients. So what is our main take-home message for this PAM50 testing? That in general, gene profiling methods provide a more concordant data that match clinical observations than immunohistochemistry alone, and additional benefits such as the manufacturer-provided ROR scores provide additional information. However, you have to use these tests with caution, since there's a limited number of studies, especially real-life data. There's limited clinical use of these novel typing methods, and more randomized studies are required. And with that, I thank you very much for listening to me, for your attention.